Hello, my name is Clifton Bannerman. Today I will be talking to the class about emergency airway management. Before we get started, just a little bit about myself. Again, my name is Clifton. I am a licensed paramedic in the state of North Carolina. I've been working for a service doing 911 operations, pretty high volume. We see about 80,000 calls a year. We run about anywhere from 10 to 15 trucks at a time. I've been doing that for about 6.5 years now, getting closer to 7 years. It has been a very interesting and fulfilling time, but I am looking to expand myself into the world of education. So here we are. Today we are going to be talking about emergency airway management in the pre-hospital setting. So I'm going to cover a wide variety of topics ranging from very BLS maneuvers that are utilized by basic EMTs, first responders, and I'm also going to move on up and talk about more ALS things that are utilized by paramedics. So before we get started, I want to go over our objectives for this classroom discussion. So we are going to discuss various airway management techniques. We are going to ensure that the student is able to feel competent and confident in performing various techniques such as the head tilt chin lift maneuver, a jaw thrust, utilization of a BVM, it's a bag valve mask, OPAs and NPAs, oropharyngeal airway and nasopharyngeal airway. Other blind insertion airway devices, both supraglottic and extraglottic, such as the King airway or the iGel airway. We're also going to go over endotracheal intubation, and we're going to touch on cricothyrotomy. After discussing all of those aforementioned procedures, I'm also going to talk about who we should do these procedures to, when we should do it, and why we should do it. We're also going to discuss some concepts related to difficult airways and how to assess for a difficult airway. And at the end, we will wrap it all up and do a nice, pretty present for y'all. So first, let's talk about who needs to have their airway managed. So for the purpose of this lecture, airway management is not going to include things like applying a nasal cannula or a non-rebreather. Those, for the purpose of this discussion, we'll think of those things: nasal cannula, nebulizer, non-rebreather, things like that. That is going to be you delivering a medication in the form of oxygen to the patient. You're not actually, managing or altering or maneuvering that patient's airway. For the purpose of this discussion, it is going to be just airway management. So we are manipulating, we are using an adjunct or a tool, we are moving, we're doing something to their airway to change it and hopefully improve it. So that is what we are going to call airway management today. So before we talk about the different adjuncts, tools, maneuvers, things like that, we've talked about kind of what airway management is, but we need to establish when we need to do this. So for the most part, someone who is alert, they're talking to you, they have what's called a patent airway. So their natural airway reflexes are intact, their gag reflex, their ability to clear blockages, secretions, fluids, stuff like that. If I were to grab a glass of water right now and it were to hit my tracheal opening, I would cough and I would clear my airway because I'm alert and I'm able to do that. In the pre-hospital setting, we will encounter patients who are not alert and will not be able to clear their airway. So anybody with a decreased level of consciousness can be a candidate for airway management. And this decreased level of consciousness can be from a variety of etiologies. This could be because of trauma. This could be because of drug overdose. This could be because of becoming obtunded after experiencing prolonged respiratory distress. This could be a diabetic ketoacidosis patient who's profoundly acidotic and extremely altered. The list goes on, but this list is anyone who has a decreased level of consciousness. How do we measure consciousness? Typically in the pre-hospital setting, our go-to tool is the Glasgow Coma Scale, GCS. So that's a scale ranging from 3 to 15. The scale is not perfect. It was made to assess patients in the neuro ICU who are in a coma, so it has its limitations, but it's a pretty good starting point for helping us quickly assess a patient's level of consciousness, mental status. So there's no hard and fast rule for if their GCS is less than this, you need to manage the airway. You may hear, I've heard this before, I don't really like it, I'm just going to go ahead and put it out there. GCS less than 8, intubate. They're kind of getting on that idea of once your GCS goes below a certain point, hey, we need to take their airway, we need to intubate them, place an endotracheal tube into their tracheal opening and breathe for them. It's okay, but it's not a great tool. You can have a patient with a GCS of 6 who is still able to clear their own airway and probably doesn't need to be intubated. You could have a patient with a GCS of 8 or 9 or 10 that, based off their clinical presentation and their expected clinical outcome, they may really need to be intubated sooner rather than later. So I don't want to give y'all a hard and fast rule of, oh, this is when we need to go ahead and intubate, or we need to stick an OPA into their airway, or whatever it is. But just remember, decreased level of consciousness to the point that you cannot control your own airway. Once your airway reflexes have been relaxed and the patient is pretty flaccid, generally that's when we're going to talk about managing an airway. And each airway tool, adjunct procedure, they all have their own special considerations. So using a bag valve mask, they may not need to be as altered or have as low of a GCS score to utilize the bag valve mask than someone, say, who's going to get an OPA into their airway. To get an OPA in your airway, you probably have a GCS of 3, 4, 5, and you cannot have a gag reflex. So you're going to be way on that low scale of almost completely unconscious. I just wanted to highlight the kind of range of level of consciousness and using airway adjuncts. So that is when we're going to use it. And then we're also going to talk about who we're going to use it on. So I'm going to save this for the specific airway interventions. So to start us off, let's talk about the head tilt chin lift. This is probably the most basic of airway maneuvers that is on the list we're going to talk about today. So I'm going to start with the most basic BLS airway and then move on up to ALS procedures. So head tilt chin lift. This intervention can be performed in a variety of situations, but essentially this is the patient who is profoundly unconscious. Their GCS is going to be maybe a 3, a 4, a 5, but for whatever reason, this patient, they are not able to keep their own airway open. So I want y'all to think about if you've ever listened to a larger man or woman snore very, very loudly. Imagine maybe grandpa or someone in the recliner and they are just snoring up a storm watching Sunday Night Football or whatever. So I'm going to turn, and I want you to imagine someone like this, and they're just snoring away. You can hear that occlusion of their tongue in their oropharynx kind of right in here. And there's They're just snoring up a storm. So head tilt chin lift is you're going to tilt the head like this, and then you will lift the chin. So look at the difference between this and this. So any patient who is laying there with their airway like this, they're probably pretty unconscious to not be able to adjust their own airway. Again, this could be a patient who experienced a drug overdose, or someone who is experiencing severe respiratory distress and they're starting to decline and become obtunded. The goal of this procedure is to open up that airway. For the purpose of this discussion, I am assuming we all have a basic knowledge of the anatomy related to the airway. But so again, that head tilt chin lift is we are going from this and we're going to this. I like to call this the sniffing position. When we are manipulating an airway, generally the sniffing position is the ideal position to get to. When you imagine like you're smelling something nice in the kitchen and you're going like this and you're smelling, that is going to open up your oropharynx. It's going to take pressure off this area right in here, open it up, and allow for easier gas exchange through your mouth and nose and into your lungs. So sniffing position is ideal. This procedure, head tilt chin lift, is usually used in conjunction with something else, but it's usually the first step in your patient treatment. So let's say I wanted to ventilate a patient with the BVM. The first thing I'm going to do is I'm going to walk up to the patient and go, arrive at the decision to use the BVM. And once you arrive at the decision, you will manipulate their head back, and then with your thumbs, lift their chin up. And that allows for a lot better breath exchange than that. So, again, that is the most basic of the airway procedures, one of the most basic. One specific contraindication to this procedure is a patient who has suffered a traumatic head or neck injury. So if I have a broken cervical spine because I just crashed my motorcycle going 80 miles an hour, it's probably not a good idea to crank my broken neck back like that in order to ventilate me, right? So in the specific instance where you need to open a patient's airway, but they've experienced severe head or neck trauma and you're really concerned about manipulating that cervical spine, instead what you're going to do is perform a jaw thrust maneuver. So it's kind of like half of that head tilt chin lift. All you're going to be doing is placing a finger or thumb here behind the mandible, and you're going to be thrusting that jaw forward. And all you're doing is opening, I don't know how well y'all can see that, but imagine like you're trying to imitate Sonny from The Godfather, right? Or, Sylvester Stallone in one of the Rocky movies with his big old chin forward. The purpose of this, again, is to open the airway and allow you to pass air into the lungs and CO2 out of the lungs more easily, but in a situation where you're not able to manipulate the head, usually because of worries about trauma or some sort of reason that you cannot manipulate this neck. There is also the possibility that your patient has such severe spinal stenosis, kyphosis, etc., that you just simply cannot tilt their head back for whatever reason. So head tilt chin lift is the main airway opening procedure. Secondary, if you shouldn't be doing the head tilt chin lift, then you can do a jaw thrust. Again, these are two of the most basic of the procedures involved with emergency airway management. Those two procedures can be performed by EMR, emergency medical responders, the lowest EMS certification level interstate, EMT basics, AEMTs, paramedics, critical care paramedics, nurses, anybody and everybody can and should perform these basic maneuvers. Just those two basic maneuvers can rapidly improve your patient's outcome. I mean, just that simple airway positioning can make a world of difference. That can take the CHFer who was desatting with an SpO2 of 50%, that can take them back up to 80% just by allowing them to breathe naturally more easily. So do not discount basic airway maneuvers when you're considering airway management. So now that we've talked about those two kind of airway positioning things, I want to talk about procedures that utilize tools. So you heard me mention it earlier, but the BVM, the bag valve mask. This tool is used by just about any and every pre-hospital provider out there, from basic EMTs to paramedics. It is used to ventilate your patient. You can use it to either assist your patient who is ventilating but maybe struggling to do so, or you can do it in the patient who has zero ventilatory effort. But the purpose of this is to use a bag. You squeeze the bag, it pushes air through a mask that's fitted over your patient's face like this, pushes air through their oronasopharynx down into their lungs. You'll get chest rise and fall, and then the air comes back out. You will hook your BVM up to 100% supplemental oxygen to ensure proper oxygenation of the patient. The BVM will come in a variety of sizes. There's usually an adult size, a pediatric, as well as a neonate or infant size. So, and what changes with that is both the size of the mask and also the size of the reservoir of your bag. So your adult BVM can hold about 1,000 milliliters of air in this bag reservoir that you squeeze. That does not mean that you are squeezing 1,000 milliliters into your patient. In general, whenever I am instructing students on how to use a BVM, I tell them to hold the bag in a very relaxed fashion. You know, you don't want to be squeezing the you know what out of the bag. You just want to barely be kind of between your thumb and your middle finger, and you're just squeezing that bag just barely together. You're not crushing an apple with your hand, you're just squeezing that bag together. And when you are squeezing that bag to ventilate your patient, I want you to do this ventilation over about 1 second or so. So this is real speed how I would go. I would hold the mask to the patient's airway, and to squeeze, I would squeeze, let go. Squeeze, let go. So it's not a snapping turtle squeezing, slamming that thing shut. You want to do it nice and easy. Slowly push that air into your patient's lungs, and then let go and let them exhale. Again, this maneuver is performed on a wide variety of patients. It could be patients who are semi-conscious and they're not ventilating great, but they do need some help. So you can use the BVM to assist in ventilations to improve the patient's oxygenation, or you can use it in the patient who is profoundly unconscious or close to it. So if your patient's GCS is 3, 4, 5, 6, you should probably consider using a BVM to assist in your patient's ventilations and respirations. BVM standard, if you're assisting ventilations, you should just match your patient's ventilatory rate. If they are not breathing at all and you're just doing all of the respirations for them, then you should be going about every 5 to 6 seconds. That does change if you're doing cardiac arrest care. Refer to your local BCLS or ACLS guidelines for specific considerations for timing and squeezing the BVM during cardiac arrest care. But if you're just ventilating for your patient, every 5 to 6 seconds, you should be squeezing that bag, getting a breath in there. Now, with your pediatrics and neonates and infants, that rate will go up. So if you've got an infant and you're squeezing the BVM, every 2 to 3 seconds, right? So literally people need faster and smaller respirations. So I want you to also think about the BVM. I kind of talked about what it is and why we do it, but who do we do it to? So earlier when we were talking about head tilt chin lift and the jaw thrust, those two things are the first step. The second step is the BVM. So if you're having to open a patient's airway, they need help breathing. You're going to be squeezing that BVM and breathing for that patient. So why are you doing this? You're doing this because you are going to be helping oxygenate that patient. You're pushing air in and allowing CO2 to exchange and then come back out. So again, profoundly unconscious patients or patients who are becoming more and more unconscious and they need assistance with their ventilations. That's who you're squeezing the BVM on. Another thing that can be used in conjunction to improve the outcome of the BVM. So squeezing this mask and bag and forcing air in and out is not the most ideal way to ventilate your patient. It is very quick and relatively easy and less invasive, and it is very commonly used by a lot of pre-hospital providers. It's not ideal in that you're forcing air from here into your tracheal opening in your larynx right here. So how can we improve, better facilitate the exchange of air from your lungs out and back in? So two of those things, head tilt chin lift, jaw thrust, that opens up the airway. But we do have a couple other tools that help us kind of keep that airway open and help that air pass back and forth more easily. Those two things, two pieces of, each one is a piece of plastic. Does anybody happen to know what I'm talking about? They are commonly abbreviated to 3 letters. Anybody? Anybody? All right, so we have the OPA, and then we also have the, very good, yes, James, the NPA. So NPA stands for nasopharyngeal airway, and then OPA stands for oropharyngeal airway. These two things are both little pieces of plastic. NPA is it looks kind of like called a trumpet. It's a flexible tube, and it's got a opening, the flared opening on the end of it. So that can pass through either nair. You insert it, bevel towards the septum, insert it, and then rotate until that flared trumpet end rests against the nair right here. And now that provides a wide open pathway from your nostril right here all the way back, and sometimes you can actually see it to the oropharynx in the back of the throat. So that allows for better air movement in and out of the patient's airway. The OPA passes through the oropharynx, and it is a rigid piece of plastic, kind of shaped like a hook. And then on the end of it, there's a flat piece that goes around the patient's teeth. So the point of this is to keep the tongue lifted up out of the way. So if you were to look at it from a side profile view, it would be curved like this, and it would curve down, maybe like this. It would curve down the patient's airway, and it would be kind of pulling or holding the tongue this direction towards the front of their airway to keep it from hitting the back of the throat and occluding that airway, which would cause problems when you squeeze a BVM and you're trying to push air into their lungs. So Those are two devices that are very commonly used in conjunction with a BVM and with the head tilt chin lift and or the jaw thrust. Those all are kind of in the same group of basic airway maneuvers. Please do not discount these maneuvers. All of the things that I have mentioned so far are extremely important, and the vast majority of the time, that if you can do those things properly, you can manage 98% of your pre-hospital. I made that number up. That may not be precise, but you can manage the vast majority of your pre-hospital airways that need managing, and you can manage them very well with just those procedures. Maybe not for a terribly long time, maybe not for an hour and a half down the road, but in the immediate, going from nothing to something, that can be a world of difference right there. If you can effectively manually manipulate the airway, get into the sniffing position, and then insert an adjunct like the OPA or the NPA, and then properly use the BVM, at night and day. You can make the patient's outcome way better, because what's the goal here? Improving air exchange and improving oxygenation for your patient. So ABC, those are the two most important things in your ABC part of your assessment. So that can be the difference between death and permanent disability and walking out of the hospital perfectly fine a couple days later. So special considerations for your OPAs and your NPAs. If your patient is profoundly unconscious and they have no gag reflex, then your OPA is good to use. If your patient is semi-conscious, if they do have a gag reflex, or if you expect the patient's consciousness to rapidly return in the next couple minutes, you should not use an OPA. So OPAs, what do? They go into the oropharynx to the back of the tongue and they hold it out of the way. If you have a gag reflex, it's going to make you gag. It can make you vomit, and putting vomit into an airway that the patient may or may not be able to clear, not a great idea. If you expect that this patient is going to rapidly return to consciousness soon, such as a patient who has overdosed on opioids and you've given Narcan and you're suspicious that they are going to wake up very soon, you should probably not put the OPA in there. Yeah, they may not have a gag reflex right now, but when that Narcan kicks in and they come back from their overdose, then they are going to have a gag reflex and they are going to projectile vomit all over you and your partner and the firefighters, and it's not going to be a fun time. And if the patient is semi-conscious, so if they're not completely out and you're worried about, again, that potential gag reflex, you probably should not try and stick an OPA in there, because it could cause them to vomit and aspirate on their vomit. So that's OPAs. Let's talk about NPAs. NPAs are a great tool, especially compared to the OPA. You don't have to worry about a gag reflex, right? It's just in your nose. It's not super comfortable, but if you're looking at your patient and you're like, they're semi-conscious, or they have a gag reflex, or maybe this is an opioid overdose and I expect them to return to alert and oriented status in the next 5 or 10 minutes, an NPA is a wonderful choice. So your opioid overdose, you wake them up, they wake up and sit up and say, oh, what happened? The NPA is fine. You have to pull it out, and it's not the best feeling in the world, but it's not going to cause them to vomit immediately, potentially compromising their airway or making a mess. The one consideration for NPAs is if they have extensive head trauma, this device is contraindicated. If you're suspicious that they've got a skull fracture, notably basilar skull fractures, or any sort of bad trauma affecting their sinuses or their skull cavity or anything through here, you should not be inserting an NPA. There is a risk and a concern that if there were to be a fracture or a hole somewhere back in their sinuses into their cranial cavity, that NPA could perforate and go into a space where it's not supposed to be. You know, you've got various voids and spaces and whatnot below your eyes, behind your sinus cavities. You don't want to go poking a piece of rubber back into your skull trying to figure out where the bottom of your brain is. So basilar skull fractures, facial trauma, things like that, no NPAs. Stick to an OPA for that one. So those all BVM, OPA, NPA, head tilt, chin lift, and the jaw thrust. All of these things can and should be performed by, in the state of North Carolina, by EMR's EMT basics. Again, just because you're a paramedic or an AEMT does not make you above these things. Yeah, your basic partner or your basic firefighter, they may be on scene first doing those things, but you absolutely need to know how to effectively use a BVM and ventilate your patient. You need to know how to use OPAs and NPAs effectively, and you especially need to know how to use the head tilt, chin lift, and the jaw thrust maneuver. You need to be able to manually manipulate your airway in order to properly facilitate adequate oxygen exchange and air exchange in and out of your patient's airway. So let's move into some more advanced things. We're going to talk about other blind insertion airway devices, such as the King Airway and the iGel Airway. So we have various commercial devices that we can use to insert them into the airway, attach a BVM, and then ventilate the patient. The two ones that I mentioned, the King Airway and the iGel Airway, are two different commercial devices. One of them, the iGel, sits above the glottic opening, and one of them, the King, actually goes into the esophageal opening. So kind of different in their how they get the job done, but they both get the job done. So we'll go over King first. King is a commercial airway device. They range in various sizes. And they are sized by height. So when you pull out your airway bag and you have a bunch of King Airways in there, you need to look at the height. They're color coded. There's a number 5 that's purple. That's for patients with a height of 6 feet and up. And then there's a red King, number 4. It's for patients from 6 feet to 5 feet tall. There's a yellow one, and it's a number 3. That's for patients 5 foot to 4 foot tall, so forth and so on. We do not carry King Airways for pediatric patients, just the adult, the 3, 4, 5. I would refer to your local protocols as to how low you want to go with the Kings. But the purpose of the King is that it has 2 balloons. When you insert it into the airway, the first and bottom balloon will go into the opening of the esophagus, and then a big balloon inflates. And the point of that is to shut off access to your gastric contents, your esophagus, your belly. So once it blocks that hole, the only hole left is your tracheal opening. Then there is another small balloon above that that inflates, and that blocks access to the rest of the world. So it's essentially filling up oropharynx and then the opening to your esophagus right here, and blocking those 2 spots, and in between is your tracheal opening. So then when you squeeze a bag, air goes in and out of the trachea. That's kind of how the King works. It normally comes with a syringe, 50 milliliter syringe, and that way you don't have to go find your own. You open your bag, you have your King device and your syringe. You'll insert the King Airway in. Sometimes use digital manipulation, so you'll take 2 fingers, you'll pull their jaw and tongue back, and then you'll insert the airway. You just sink it until the top of the tube hits the teeth. Then you inflate it with the 50 milliliters of air, pull it back a little bit to seat it, and then attach your BVM, squeeze it. If you have good chest rise and fall, equal chest rise and fall, then you know that you've performed the procedure appropriately. If you're just hearing a bunch of air flapping out of here, or you see the belly moving up and down, then you're not in the right place. You need to deflate, pull out, and try again. The King should only be used on patients who are profoundly unresponsive and do not have a gag reflex, and you do not expect them to rapidly return to a state of full consciousness. These patients are very sick and unwell, and they are going to let you insert a giant piece of plastic into your airway. You're going to jam it into them and breathe for them. They need to be completely unconscious for you to do this. These tools are very commonly used in cardiac arrest patients. They're also very commonly used by fire departments and by BLS services, as it's usually the highest form of airway management and most secure form of airway management that they have. It is better in the BVM and mask in the sense that you are cutting off the esophagus. And that is beneficial because if you just have a mask and then you're squeezing air in, there's two openings in here, right? There's the opening to your trachea. That's the one that's more forward, more anterior. And there's the opening that goes to your stomach, which is your esophageal opening. So if you're applying equal pressure into your oropharynx, you could also be pushing air into your belly. This is bad for a couple of reasons. You're going to, as you continue to do that, you're going to inflate your belly and increase the pressure in your abdominal cavity. Now, what are some of the main vessels that run through your abdominal cavity? Is your descending aorta and your descending vena cava. So that's one of the main garden hoses that takes blood to your lower half of your body, and then the other one, the descending vena cava, returns the blood back up to your heart. So if you increase the pressure of your intra-abdominal cavity, you're going to be increasing the pressure on those two vessels. So if you increase the pressure on those two vessels, you're going to reduce the blood flow out and reduce the blood flow back to the heart. This can be really bad for a patient who is experiencing a pretty advanced illness if they're being ventilated with a BVM or a King Airway or something like that. So decreasing cardiac output and decreasing venous return is generally bad for your unstable patients. So this is why it can be better to use an airway device that takes away the possibility of inflating that stomach and increasing that intra-abdominal pressure. That's why we look at things like the King and the iGel and the intubation as superior than just a BVM paired with an OPA or an NPA. So King Airway, and then we also have the iGel Airway. The iGel is a little easier. You don't have to inflate it. All it is a piece of plastic, a tube, and it's got a mask looking thing on the end of it. And all you have to do is insert that into the patient's airway, and it kind of does the same thing. It doesn't fully seal off the esophageal opening like the King does, but what it does is it has this mask seal, and it comes into your airway, and it basically seals off around your glottic opening, going to your trachea into your lungs. It seals completely around that. That way, when you squeeze the bag, you're just pushing air into and out of the glottic opening. One disadvantage is that you are not sealing off your esophagus. So there still is the opportunity for gastric contents to come up into your oropharynx if the patient were to vomit. You would hope that your iGel would be sealed around the glottic opening and you wouldn't get any vomit in there, but it's not ideal. So that is one downside to the iGel. Both the iGel and the King Airway can and should be secured, hopefully with the commercial securing device of your choice. If you don't have the commercial securing device, you can use twill tape or medical tape or whatever you need to get it done. But just secure that airway in place. The commercial devices are nice. It's got a mouthpiece. It fits onto the mouth, and there's an opening for the tube, and usually a little tightening thing that'll tighten an arm down onto the tube and hold it in place. So then a strap will go around the back of the patient's head, Velcro strap that thing on there, and it'll hold that tube in place. So that way you don't accidentally, dislodge the tube one way or the other. So Kings and iGels are both a form of a blind insertion airway device. So the idea is that you can't see into the airway. You're just blindly going, well, I know they need to breathe better, so I'm going to stick this airway device in there and hopefully it does the right thing, right? Contraindications to this, it's tough because if you're doing this, I mean, you're trying to secure an airway, and that is the first letter in ABC, airway, breathing, circulation, right? So there's not many significant contraindications to a blind insertion airway device. The only big thing I could think of would be severe airway trauma that's going to prevent you from placing this device. Maybe a GSW or a stabbing into the neck or something like that. That being said, if you are placing a King or an iGel, you may be in an unfortunate situation called the crash airway. If those two things don't work, you're going to pull it and you're going to resume ventilations with your bag valve mask. If you're not able to properly ventilate with a BVM, this might be your last ditch effort to ventilate the patient. You're just going to try again until you can successfully do it. You're also going to be calling for more resources because this type of patient is having a bad time and they're going to need ALS interventions such as an intubation or a cricothyrotomy. So you need to be either rendezvousing with an ALS crew or getting them to the hospital as fast as possible. So endotracheal intubation, let's talk about that. So endotracheal intubation is the procedure involving the placement of an endotracheal tube into the patient's glottic opening, into their trachea. So these tubes come in various sizes. They come both cuffed and uncuffed. The cuffed have a little inflatable balloon at the end of it that inflates inside the glottic opening to secure it, and uncuffed do not have the tube. The uncuffed are the very small sizes used for small pediatric patients. So the smaller sizes could be 1, 1.5, 2, 2.5, 3, 3.5, so forth and so on. Once you get to adult sizes, you're looking at about 6.5 to 7 on the lower end, goes up to 8. So the average adult, 7 seems to be the average tube size. I would like a 7.5 in most of my average adults, if possible. Biggest tube you can fit, essentially, is the moral of the story. Bigger tube, more air, better for your patient. So 8Os are ideal, but not every adult patient can fit an 8O tube. You'd be surprised. Most adults 5'6", 5'7", and up can probably fit an 8O tube, but use your best judgment. So 8, 7.5, 7 for adults. 6.5 is when you're starting to get to really small adults, or maybe like something like a 12, 13-year-old, you know, the kind of smaller patients. And once you're about above a 3.0 and above, all your tubes should be cuffed. So they'll have that little balloon down here, and a little line and a little lower lock up at the top, and you can hook up a syringe to that to inflate it with air. There are various methods to facilitate the passage of an endotracheal tube into the glottic opening. We're going to talk about direct laryngoscopy, video laryngoscopy, and there's one more. It is the endoscopic laryngoscopy. That is usually done in the in-hospital setting, but we'll touch on it real quick. So, direct laryngoscopy. Laryngoscopy is the use of a laryngoscopic blade that you use to open the patient's airway and then place that endotracheal tube into their glottic opening. So, direct laryngoscopy consists of a blade. It'll have a handle. The handle will be about this long, enough for you to grip it. In that handle, there should be batteries in there. Usually, what type of batteries varies. and then you'll have the blade. So you'll have a handle like this, and you'll have a curved blade. Different blades in different sizes. You have a Mac and a Miller. A Mac is a curved blade, a Miller is a flat blade with just a little lip on the end. And then there's numbers. So 4 is the biggest, 1 or 0 is the smallest. Generally, adults get a 3 or a 4, a Mac 3 or a Mac 4, or a Miller 3 or a Miller 4. All of these blades have a little flashlight on the end of it. So you click the blade onto your handle, and as long as your batteries are charged up and your blade is functioning properly, you'll have a flashlight on the end of that. What you'll then do is you will take that blade and you will insert it into the patient's airway. The Mac blade fits into the vallecula behind or above the epiglottis, and that causes the epiglottis to flip up and allows you to visualize the glottic opening. You can then place the endotracheal tube through the oropharynx, through the glottic opening, and you can directly visualize that happening. The Miller blade, same thing, but it just grabs onto the top of the epiglottis and just lifts it out of the way manually. Either way though, with direct laryngoscopy, you're using a blade with a flashlight on the end of it. You're inserting it into your patient's airway, and you are pushing this endotracheal tube through their airway and into their glottic opening. You then take the blade away, you hold onto the tube, you inflate that bubble, and then you put the BVM on top of the tube and you squeeze. If you've done it correctly, you'll see equal chest rise and fall as you ventilate the patient's lungs. This is a very advanced procedure, and I could sit here and talk to y'all about this for hours and hours and hours, but that's the brief down and dirty of what it is. So in order to do this patient or do this procedure on a patient, they need to be profoundly unresponsive, either from whatever etiology they have going on, trauma or overdose or whatever, or they need to be sedated and paralyzed to facilitate this. This is also a procedure that is usually expected to be done on a cardiac arrest patient. So direct laryngoscopy is kind of the original way to intubate, but as technology has progressed, we have gotten to what is called video laryngoscopy, and this has been huge in improving the success rates for laryngoscopy procedures. So same concept, you've got a handle and a blade, right? But instead of just having to have a flashlight on the end of it and having to worry about manually opening this patient's airway and trying to look in there and see that glottic opening, that can be tough, right? It's usually not a super great look. You're having to get down low and look through a patient's mouth, like that's in this position, and look from here to their glottic opening right there. That can be tough. You know, on me, that might be easy. I don't have a whole lot of confounding difficult factors going on with my airway, but if your patient was morbidly obese, or maybe they've got trauma or a ton of airway secretions, that could be really hard. So what scientists, doctors, and engineers came up with is the video laryngoscopy. So on the end of that blade, instead of having a flashlight, someone said, well, hey, what if I put a camera down there? So they put a camera down there, and that camera transfers information up to an external screen outside of the airway. Now, I don't even have to really worry about manually opening the patient's airway to where I can visualize it from out here. As long as I can get the tip of that blade close to the glottic opening, I can see the patient's airway on a screen. There's various devices and companies that make theirs. There's the Glide Scope Go, there's King Vision, there's a McGrath, there's all these different brands, and a lot of them will have a handle, a blade, and then on top of the handle, they'll have a little screen. It could be 3 inches by 2 inches. I've used the Glide Scope that has a whole separate screen. It had a screen about that big, about 7 inches by 4 inches. And it had a cord that went to your handle and blade. But you could set your screen just maybe on the patient's chest right here, or off to the side on a table or a bench. So you could be intubating a patient sitting in front of you or laying in front of you, and your screen could be over there, and you just are doing your thing with your intubation, your laryngoscope blade and your endotracheal tube, and you just could be going in here and looking at your screen over there. The invention of video laryngoscopy has vastly improved the first pass success rates of intubation. It makes it so much easier when you don't have to worry about manually displacing airway anatomy in order to facilitate a view. You just slip in there, curl your hand up and get that blade in the right spot, get your tube in there in the right spot, and pass that tube. Another wonderful aspect of video laryngoscopy is the fact that you can, with a lot of these devices, you can record your intubation attempts. So this is great for verifying that you properly placed that endotracheal tube in the glottic opening, and two, for performance and review and performance improvement. So after the fact, you and your PI committee, y'all can look at these intubations and go, wow, that was a good one, or that was a bad one, or they should have suctioned more, or they should have lifted, done this or that. And it can really serve to improve your services and providers' proficiency and competency with video laryngoscopy procedures. So if you're a 911 service and you're thinking about getting video laryngoscopy, please do it. It is leaps and bounds better than just direct. So another one that I wanted to touch on real quick was the endoscopic procedure. Similar to video laryngoscopy, but instead of having a blade and a camera on the end of the blade where you're opening the patient's airway, it's just an endoscopic procedure that's similar to other procedures used throughout the body, but essentially a flexible little snake guy with a camera on the end of it. So you can just snake that into the patient's airway and you can see where you're going. So you just snake that thing on up in there and into the glottic opening, and then you just railroad your endotracheal tube right over that and then pull it out, and now your tube's in place. Generally not performed in the pre-hospital setting. Normally in the pre-hospital setting, you will just have direct laryngoscopy and or video laryngoscopy. So you have laryngoscopy, but let's talk about cricothyrotomies. This is kind of the ceiling of emergency airway management. This is the last ditch effort of airway management. The cricothyrotomy is the procedure of opening up the patient's trachea and passing a tube directly from outside their body through their trachea and into their tracheal opening, so that way you can ventilate that patient. It can be accomplished through a couple different ways. The most common way for adults is going to be, they call it a couple different things. You may hear front of neck access, FONA. You may hear open surgical technique or just surgical cric. But what that involves is taking a knife, making an incision on the front of the larynx at the cricothyroid membrane. And to do that, you're going to first feel for your Adam's apple. Essentially, that's the horn on the larynx. I don't know how well you can see, but you're going to feel for the tip of the Adam's apple, and you're going to move down. And you're going to slide down, and then you're going to feel another bump. So you're going to have a high point, and you're going to come down, and then you're going to feel another high point. So between that mountain and mountain, there's a valley. That valley right there, you feel that Adam's apple, and then you move down. And that flat part, that valley right there, that's your cricothyroid membrane. If you take a scalpel, you make an incision, you take that same scalpel and you puncture through that cricothyroid membrane, and you rotate your scalpel, and then you stick a bougie or some sort of hard plastic thing into that incision that you just made, you are now in the trachea. You just bypass, just above you is the glottic opening, but if you keep going down, you're gonna move through the trachea and then hit the carina and then the two lungs. So for whatever reason, if you could not intubate or manage an airway from up here, you couldn't use a BVM effectively, you could not use a King or an iGel effectively, and you were not able to intubate after multiple attempts, and your patient still doesn't have a secure airway, and they're desatting and they're declining, and you need to secure it, this is the last ditch attempt. You're cutting open their airway, you're inserting a tube in there, and then you're breathing for them. It can be very scary, but it is something that if it is in your scope and it is something that you could possibly end up doing, you need to train on it. This is the absolute epitome of low frequency, high consequence intervention. Most of us will go our entire careers and we will never have to do this. And personally, I'm okay with that. This is not something I particularly want to do. It's going to be scary and stressful and bloody. And if you are doing it, that means that your patient is going to die if you don't succeed. So this is literally do or die. Doesn't sound like a good time to me. But that does highlight the importance of proper training. We absolutely need to feel somewhat comfortable doing this procedure. Every year, your service should be getting you some pig tracheas and walking you through all the steps on how to do this with your medical director and training department staff present. I mean, this is something all hands on deck. We need to feel comfortable doing it, because if you don't, when you know what hits the fan, you're not going to want to do this. You're going to skip it and just try and intubate over and over, and the patient could die because you were too afraid to pull the trigger because you didn't have the proper training. This procedure is stressful, but if you break it down and you train, it actually is a relatively simple thing. If it's an adult and you're doing surgical technique, you're just cutting a hole and sticking a bougie through it, and then once the bougie's through, you put an endotracheal tube over that, and then you inflate the cuff and you're good, and then you're ventilating and you're off to the hospital to definitive care. There are two other techniques that are sometimes and more often used in pediatric patients. So you've got a needle cricothyrotomy, and then you've got the Seldinger technique. So the Seldinger technique is similar to a needle. You're sticking a needle through that cricothyroid membrane, and then you're using an introducer device to go, you're gonna put a guide wire through that needle, and then you're going to put an introducer device over that guide wire. And that's going to kind of slide into that little hole that you made and made that hole a little bit bigger. And then over that introduction device and wire, you'll then slide a commercial device that will slide into place. You'll be able to secure it, pull the wire and introducer out, and then you'll just have a plastic going through the trachea right there that you can ventilate on. You've also got the needle cricothyrotomy. That involves just needle puncturing through the cricothyroid membrane and then having some sort of adapter device and leaving the catheter in there. You would take the needle out and just leave a catheter, and then you'd be able to ventilate through that little catheter that you inserted via needle. That normally requires the use of a jet ventilator or is used on very tiny pediatric patients. So just refer to your local protocols for the specifics to those procedures, because they can be performed. There's little nuances in what you use and what kind of equipment you use, and there's dozens of different ways you can accomplish this. So again, talk to your medical director, talk to your service, and you look at your local protocols to figure out what they want to do if they are utilizing Seldinger technique or needle cricothyrotomies. So now that we've kind of gone over all the different emergency airway techniques, I do want to hit on ways to identify difficult airways. So these patients who you're managing their airway, there's a good chance that they are not the healthiest people, right? So these patients may be obese, they may be smokers, they may have tumors in their airway, they may have stuff going on. So there are various mnemonics that you can use to assess a difficult airway as it relates to using a BVM, as it relates to using an extraglottic device such as a King or an iGel. difficulties related to laryngoscopy and as well as cricothyroidomies. So I'm going to give you 4 mnemonics. Some of these letters will overlap, so keep that in mind. You'll hear the O one overlap a lot, but for BVM, you've got Roman. So Roman, R is radiation or restriction. So do they have some sort of restriction to their neck, like spinal stenosis? That would stop them from, that would maybe keep them locked like this to where they can't lift into the sniff position, right? Or radiation, do they have neck cancer, throat cancer, any sort of cancer where they got a bunch of radiation right here? That can distort the anatomy of their airway and make it different and weird. So O, obesity or obstruction. If someone's obese, they get a lot of weight right here. That weight can change how easy it is to manipulate their airway. And obstruction, do they have a giant piece of steak in their mouth? Do they have a Japanese fighting sword through their neck right now? Is there some sort of manual obstruction in their airway? M, mask seal. So bag valve mask, remember you've got to get that mask sealed onto their face so that you can squeeze the bag and push air in and out. Things can make that mask hard to seal. So does your patient have a full beard or a goatee or something? That could make it hard to get a good mask seal. Does the patient not have any teeth? If their dentures are laying on the floor over there and their mouth, then it may be hard to get a full seal because their cheeks, could be sunken in, making it hard to form that seal. A is for age. So again, geriatric patients, they could be harder to ventilate, get a good mask seal, because as you get older, you lose fat and tissue right here and here. So those really old patients where their faces are sunken, it can be harder to ventilate them. And then N, no teeth, dentures, if they don't have any teeth, can make it hard to ventilate. All that kind of ties back into the mask seal. So that's BVM, that's Roman. So for extraglottic device, you've got rods. Remember those repeats I talked about. R, restriction, radiation. O, obstruction, obesity. It's the same as with Roman. D, disrupted or distorted airway. Kind of ties into the R, but if they've got something that's changing the anatomy of their airway, it can be hard to stick this device in there. And then S, short thyromental distance. So this I talked about with the King airway and the iGel. There's different sizes based off the height, right? And they do it off of height and not off of weight, is because as you get taller, the distance from here to here changes, it increases. So a 7-foot tall basketball player is going to have a much longer and taller airway than a 5-foot tall gymnastics person, right? So the size of those airway devices increases and decreases based off the size of the patient's airway, which is directly related to their height. So if they're really, really short and they've got a really short neck, that can make using the King or the iGel, make using it harder. You may need to go down a size. Laryngoscopy, we're going to use lemon for that. So to evaluate for a difficult airway using the lemon mnemonic, you're going to look externally. So just look at the patient's airway. Just you standing there evaluating them. Does it look like it's going to be difficult? If you were to lay me down on a stretcher and put me in a sniffing position, my airway is probably pretty easy to assess, and I'm probably pretty easy to intubate. But if you look at someone and go, oh, I don't know, this guy's 400 pounds and 5 feet tall, and he looks like he has no neck, or, that's step one in going, okay, this could be a difficult airway. E, evaluate. So you're going to do the 3-3-2 method. So 3 fingers and 2 fingers, right? So 3 fingers, you're going to use this to measure your patient's airway. If they don't meet, if it's shorter than the 3-3-2 I'm about to show you, it could be a difficult airway. It's smaller than it's supposed to be. So you should be able to go from the bottom lip 3, and then 3, and then 2. So from larynx right here to bottom of the chin should be 2 fingers. If you hold your fingers like this, it should be 3 going from chin to the neck, like this. So I can fit 3 right there, and then 3 right here. If it's only 2 right here, or maybe only 1 right here, smaller airway could be difficult to perform a laryngoscopy on this patient. O, obstruction, obesity, same as it was the other 2 times before. And then N is for neck mobility. So are you able to move the neck around? If you can't, it could be a difficult airway. And for cricothyrotomy, we're going to use the SMART mnemonic. So S stands for surgery. Have they had surgery right in here before? Have they had a tumor removed or some sort of cancer surgery? Do they have a tracheostomy already? Things like that. That could make things difficult for you. M, mass. Do they have a tumor? If they do, that could get in the way. A, access and anatomy. Is their anatomy different or changed at all? Are you able to get right here? Or is access difficult? R for radiation and T for tumor. Tumor and mass are kind of redundant, but SMART sounds like a nice mnemonic, doesn't it? It sounds a lot better than just SMAR or SART, right? So I know it's a lot to remember, but those 4 mnemonics, if you learn those, it will get you in the headspace of thinking about difficult airways and thinking about how to best manage your patient's airway. You know, you can sit here in class and practice all day long on a mannequin who's probably a very stereotypical average male human, all right? They're not gonna be very difficult to deal with. I mean, they're made of rubber and can be a little hard-headed sometimes, but to get difficult airway practice, you're gonna have to do it in the field or in the hospital somewhere, right? So I want you to practice all of the procedures that we did today or talked about today and practice them and get competent and proficient with them. But remember that in the field, when you're dealing with patients, every patient is not going to look like me and have a nice, easy airway. If you go to use a BVM on somebody, or you go to insert a King airway device, an NPA, an OPA, you want to intubate them, you've got to do a cric on them, whatever it is, you're going to encounter patients that are obese or have had radiation or have facial trauma or have something going on where it's going to make things harder than just you sitting here with me in the classroom and intubating the same mannequin head 15 times in a row. So if you consider the possible difficulties associated with an airway and you anticipate them, then your outcomes and your success rates can be far higher than if you just go in there assuming every airway is the same, every airway is easy and perfect, and it's just like it was in the classroom, right? That's why it's important to talk about the different roadblocks you may encounter when trying to manage the airway. So, in review, I talked about a lot today. Training is of the utmost importance. I cannot stress that enough. Depending on where you work, if you work the setting that you're in, you may or may not get a lot of good repetitions. So both quality and quantity of repetitions involving airway management is important. So we can work on quantity pretty easy, right? I can sit here and have you intubate this mannequin head 25 times today, and that'll get you a good quantity of repetitions, but they're not the best quality. The best quality is going to come in real life situations, intubating real patients in the pre-hospital setting. Now, that being said, some people work in slower services, some people are white clouds. You just don't always get all of those repetitions. So that's why it's important to balance both quality and quantity. If quality is lacking, we can at least increase quantity to try and compensate for low quality, right? And vice versa. Ideally, we have both high quality and high quantity, but we take what we can get, right? So continuous and high quality training are very important. All of these procedures are equally important. Do not neglect cricothyrotomy or laryngoscopy training because that's not in your scope, or that's not something you're ever gonna do. You don't need to do that. Oh, I just work interfacility transport. Now, I don't need to worry about intubations. Not true. If it is within your scope of practice, you absolutely need to achieve and maintain clinical competency and proficiency in said task. It is very, very, very important. Again, cricothyrotomies are the epitome of low frequency. Many of us will never see it in our entire careers, but absolutely high consequence actions. If you're doing a cricothyrotomy, that patient is probably going to die soon unless you succeed in that procedure. So please train on cricothyrotomies. Again, we talked about head tilt, chin lifts, we talked about jaw thrusts, we talked about OPAs and NPAs, and how those 4 things are used in adjunct to improve your outcome with the BVM, right? The most basic thing you can do is just manually manipulate a patient's airway. You can tilt their head back, stick their chin out, put them in that sniffing position as if they're smelling grandma's cooking, right? You can use a BVM to ventilate that patient. You can use that in conjunction with the mask, bag valve mask, or you can insert a King Airway or an iGel, that's an extraglottic device, or you can just intubate the patient's trachea directly. A couple different methods: direct laryngoscopy, video laryngoscopy, and endoscopy. Endoscopy could be considered the best, but not commonly used in the pre-hospital setting. Our gold standard in the pre-hospital setting is video laryngoscopy. It improves outcomes and it improves success rates. So please use it if possible. Train with it, use it, love it. The entire idea of this lecture today has been about emergency airway management. So these are patients that we have specifically decided that they need to have their airway managed by us. So the goal is just to improve oxygenation and air exchange at the most basic level. How we accomplish it can vary, but at the end of the day, all we're trying to do is facilitate air coming in and air going out. We don't want it to go into the belly, we want it to go into the lungs, and we want to do it effectively and quickly. That's all I have for y'all today. If anyone has any questions, comments, or concerns, please feel free to reach out to me at any point. I know this has been a lot, so we're going to touch on this again tomorrow. My email and phone are available to y'all. Thank you so much, and I hope you all enjoy the rest of your day. Thank you.